strategy and the landing zones. The other variables analyzed were post-PCR optimization by OCT and ACR, major adverse cardiac events in 6 months and 1 year, time to conduct OCT and ACR, and the contrast form. Inclusion criteria: significant coronary artery stenosis, diameter more than 70% based upon visual assessment on the angiogram in at least one native coronary artery after angiography. And the exclusion criteria for those patients who are very sick, hypotensive, shock, need for support or intravenous vasopressors, patients with renal insufficiency, and patients who had contraindications to antiplatelet therapy for up to 1 year. The baseline characteristics are here, and it basically reveals that most of the patients that were included in the study were a decent blend of multiple clinical situations, most of them being unstable angina. And of course, in terms of the vessels and the lesion characteristics, the type B, type B2, and type C contributed to the majority of these cases. And of course, LAD was the major vessel involved in these lesions. Now, what we saw on analyzing the strategy, analyzing these findings, was that in terms of the strategy change from angiography to OCT,
Doctor, only 5 more minutes to go.
Strategy. And most of this was driven by the stent length and the change in the landing zone. In terms of the ACR, not much of a change in terms of the overall strategy. So there was a significant change of about 22%, and most of them contributed by the change in the landing zone again. In terms of post-PCI strategies based upon OCT, there was a 30% change in the overall strategy of treatment. Basically, most of them being driven by stent artery expansion and stent malapposition. There was no significant difference, no change in the additional strategy between ACR and OCT in the post-PCI.
4 minutes to go.
If you look at the overall strategy change in the protocol population, there were 480 lesions. We realized that almost 90% of the patients who underwent the OCT in the study had some change in the treatment protocols in terms of either pre-procedure or post-procedure, most of them being driven by a change in the pre-procedure strategy. So OCT plus ACR changes angiographic-based decisions in almost 90% of the patients. In terms of the secondary endpoints, in terms of time to conduct the OCT and ACR, no significant change in the time that is required pre-procedure or procedure or post-procedure. The total contrast used for the OCT was about 40, on an average of about 40 mils, and the success rates were 100% in terms of angiographic and procedural successes. So if I were to conclude the study, this is the first South Asian study reporting the outcomes of OCT, ACR, and PCI in patients with coronary artery disease. OCT plus ACR changed the angiographic position in almost 90% of the lesions, and pre-procedural OCT changed strategy in 76% of the lesions. Angio registration changed strategy in additional 22% of the lesions. Post-procedural OCT changed the strategy in over 30% of the lesions. We are in the process of collecting the 1-year clinical follow-up data, and this is being processed at the moment, and the follow-up is almost complete, and the additional and the data should be out in the near future. So I thank you once again for this opportunity, and I open this to the forum. Thank you very much.
Thank you so much, Ajit. Really parallels very closely what we saw in the Light Lab study here in the US. I think we have time for just one comment or question. So Azim, what I'm seeing here in the eye optical study is that if you plan your procedure carefully using the imaging pre-procedure, there's not a lot of change post-procedure. Isn't that like a TAVR?
Yeah, I guess very much. It's all about, I mean, as you know, TAVR instruction is all about pre-procedural planning and understanding before you start putting devices into the patient exactly what you're going to be doing. And I think that's what's been the biggest change in recent years, right? I remember when we did the first IVUS studies with drug-eluting stents, comparing it to angiography, and it was all about doing the IVUS at the end and optimizing and seeing how we can post-dilate to get the best result. Where now it's truly moving to
right? Doesn't make a difference. And if you plan everything ahead of time Do you need the post? Or if you don't do the pre, there's no MLD, you just do the max. What's the difference between those two? And so that's the one piece of the eye optical and light lab work that I think is missing. But nonetheless, very clear that an imaging guided algorithm like the one that we're using now all around called MLD Max really impacts clinical care. Thank you, Ajit. It was nice to see you from India. We hope things are settling down there. Okay, because of time, we're going to move.
Nice meeting you.
We're going to move right on here to our live case from, are they ready for us? This is from Lisie Hospital in Kochi. The live operator is Ronnie Matthew, Jabir A, and team. Can you connect this?
And we just wanted to add that if anyone has questions, there's the chat feature so that you can send your questions into the panel at any time.
So while we get connected, oh, here we go. All right. Oh, that's really Indian. Good morning, Ronnie. Can you hear us?
Yes, very well. Good evening to you. I'm
I
sorry.
knew you would live close to the beach.
I wish I was on the beach. Anyway, Dr.
I just
Ziad,
wanted to say welcome from us. Thank you for joining us at OPCI. We're going to let you take it away. Tell us about your case. We have an excellent panel, and we're all ears to see what you're going to show us, all ears and eyes to see what you're going to show us from India.
great. Thank you. At the outset, Dr. Ziad, it's our privilege and an honor to be part of this OPCI meeting, and I thank you for taking us for this live case. So, let me first introduce my colleagues. Dr. Jabir is there, Dr. Joe, Dr. Jimmy, Sister Betty is our chief nurse, and we have Wilson, our chief tech around. So, since I got only half an hour, I'm going to go straight into the case, and Dr. Joe is going to present the short PowerPoint presentation to you. Can we have the case, please?
Good evening. This is the story of a 39-year-old gentleman. He is a smoker, and he had an episode of angina and associated with the syncope on 4/6/2021, and admitted in another hospital where the serial ECG did not show any significant dynamic HTT changes. His troponin was positive, and he was diagnosed as a case of acute coronary syndrome, Yensteni. Next slide, please. And his chest X-ray was normal. The routine investigations, they did the CT brain also because of the syncope, it was also normal. And a coronary angiogram was done after 2 days, and it showed triple vessel disease, and he was referred to our center for further evaluation and management. This is the ECG, which is showing no significant changes except some mild T-wave changes in the inferior leads. And the echocardiogram shows no regional wall motion abnormalities and a normal LV function, no mitral regurgitation, and no other significant abnormalities. And this is the coronary angiogram. The angiogram on the right side shows a significant, almost a total occlusion with a significant amount of thrombus in the distal aspect of the RCM. And the left is injection showing, the left main shows a distal 30% lesion, and in the LED ostium there is around 70% lesion in the caudal view. In the cranial view, the PA caudal view, it shows around 70 to 80% lesion. The circumflex is normal. The rest of the LOD is also normal. Over to Dr. Roni for further discussion.
Right, so I'll tell you what our plan is and what we have done so far. So Ziad, what Jabir has done in the meanwhile is he has opened up the right coronary artery. Can we have the fluoro, please? So he has seen the RCA there, and go to the next view. He opened that up, go to the next view. It's a long lesion, so he put a 2.75, I think 38 millimeter stent in, deployed that, post dilated with a 3 millimeter, and that's the result you have. So now this has been done, and what we are going to show and discuss with you is the lesion that we have on the left side. So now let me go and show you the shoots on the left. Now, can you freeze this? There is a lesion in the osteoproximal LAD, a little bit in the left main. And of course, we had a discussion over here, so we thought we must decide whether we need to revascularize this. So we're going to look at physiology to decide if we need to revascularize this. The other issue is that this looks like an osteal LAD. So would you actually just go and just put a stent in, say that I'll nail the osteal LAD, or would you just go from the left main to the LAD? Because we firmly believe that there is no lesion that stops at the ostium or the left main. It has to go, that does not stop at the ostium or the LAD. It has to go into the LM. And I intend to show you that with our imaging also. So first, let's have a look at what the physiology showed. The IFR was 0.87. Can you go to the next view? And when we did a pullback, that's what the pullback gradient showed. There was a sharp uptick at the ostial position. To just give you an idea of the co-registered, that's a co-registered image that you can see. If you see the maximum amount of pullback gradient, the largest gradient was right there at the ostium. Having done this, just for academic sake, we just decided that we're going to do an FFR also for you. So we did an FFR also, and the FFR, if you look, is 0.73. So we got to revascularize this lesion. The next question is, now if you look at the LM bifurcation, Medina, we would say that this is probably 0, 1, 1. If you take the 50% stenosis criterion. But now if you look at the OCT, that's what he did next. Can you go next? And let's have a look at the OCT. Now this is where I want to, that's an OCT run. Can you see the OCT, Ziad? Are we connected? The lower part of the L view seems to be cut off, but at least I'll show you. That's the LAD that we are coming up. That's coming to the proximal LAD. This was done before pre-dilatation. So if you look at the lesion there, you see that's the ostium of the LAD. And can we just have the diameter and the dimensions there? Keep it there, left side, upper. Yeah, so that's around 1.96 millimeter squared is the area with a diameter of 1.5. So I guess even if you look at by OCT criterion, it is significant. Now if I come a little more proximal, now that's the circumflex ostium. The circumflex ostium looks pretty good. But if you look at the LM, see the disease goes right into the LM, and that's where I said that there can be no stenosis that stops at the LAD. We have got to go into the LM. So, and that is why we decided that we're going to do an LM crossover stenting. And I'm not so sure you all are able to see the entire lumen, but I can see it here. And we did a quick MLD max. And the MLD max shows a proximal at the left main, a diameter close to No, that is not the proximal. That is the distal that you're showing, right? Fair enough. Fair enough. That's the distal that is being shown. And the distal, the EL to EL is around about 3.2. And if you look at the proximal, let's go to the proximal. The EL to EL is around about, no, it's not 3.95, but it's a 4.52, right? So, depending on what you taught us around the MLD max, we decided that we are going to take a 3.5 millimeter stent so that we are able to take the proximal and the distal with a length of 33 millimeters. Now let me also tell you why we did this, because I'm going to use the Science Expedition here. I hope you can hear me because it looks like I'm rambling without any response from there.
No response. Yeah, they are talking something we are not able to hear.
Yeah, okay, fair enough. We can't hear what you are saying, but I'll go ahead. So now when you look at a stent, you know, and I mean it's important, and that's why I said the stent architecture is very important to decide what stent you're going to use here. So since we're using the Science Expedition, if we use a 3.5 millimeter stent, the maximum expansibility of the stent is around about 5.2. So I think that will fit very well into our left main. So we're going to do that exactly. We're going to use a 3.5 33 and go and position it right at the LM ostium without involving taking the LM ostium, and then post dilate, do a pot at the left main, recross into the circumflex with the distal strut, and I'm going to show you how we cross using the distal strut, and then probably redo an OCT to show you the distal crossing, and then KISS if necessary. And then we'll decide subsequently, once we decide on this provisional strategy, whether we should go with a T or a TAP or a culotte or as the case may be. Since we can't hear you, I don't know if you have any questions on our strategy, but I would have loved to hear from you. So we are taking the LAO view, a little LAO view, so that we are able to nail the ostium of the left main. At the same time, I don't want to come out.
You want a cranial?
I think we need to come out a little bit more. Can you give me a puff there? I think we're just right. So we're not going to go at very high pressures when we deploy this, because we know that the distal we do not want to come. Let's go there.
Okay. I'm at 8.
8. That's
10.
perfect. 10. That's hold on.
10. Okay.
Right. Can we come to the other view, please? So right now my circumflex stent is jailed.
Shall I go down?
Down. PA caudal view, please. Now at this point, it's important for me to understand that, and for you to understand that the circumflex wire is jailed.
Yeah.
So if this guide goes and hits it, you're going to get longitudinal compression. So what I normally do is we control the guide when we take this balloon out, and the first thing we do is you do a pot. So as we decided that we're going to do a pot with a 4/8. Have the technical team been able to solve the problem of audio?
This is 4/8.
This is 4/8. So we're going to go with a 4/8.
High burden and
Yeah.
thin cap fibroatheoma and the proximally deep.
Great. We are able to hear you
I
now.
mean, while you joke about that, Andy, the appropriate use criteria kind of shifted us towards that, right? You can't treat simple lesions. So what ends up happening is you see older, sicker patients with a higher syntax score and more burden of atherosclerosis, which is why if we're going to do the PCIs, optimization is so important.
Ziad, we're able to hear you now.
Zim, what would your strategy be in this case?
Yeah, I think just angiographically, you could tell that you're going to have to land the left main. Probably I would have landed on the body of the left main because I'd be concerned about how big the ostium gets, and I don't think you always need to cover the ostium. Leaving out for a plot, the question is, what do you get from the panel? Does everybody kiss now for left mains? If you have a great result after provision with the plot, or you leave it alone?
We did a little bit more. Can you give me a zoom there, please?
Comment on this, I think the pullback, the good news
Go up.
with the ocean circumflex is
You want me to go?
Go.
disease. I think there is a high likelihood that you will not need to kiss.
14, 16.
I'm not dogmatic.
Down.
But, you always
Now I come to
The
the
old school teaching was for left mains, you always kiss because you may have to come back in the future. There's patients that have distal disease.
10,
but
12.
I don't think you have to.
Can we have an angio stent to decide where we are?
12.
Fine.
14,
I
16.
don't necessarily
Down.
kiss either.
So it's interesting. I would say the best two data sets are completely opposite of each other. So the Korean registry shows
12,
a doubling
14,
of the MACE
16.
rate if you kiss.
And
That's a
14,
registry.
16.
In Excel,
Down.
the kiss made things better. So
Wilson,
it's
wala idea
an
on left
unanswered
main
question. In
there,
fact, if we
ostit
get
lion.
audio from Ronnie, Ronnie has an amazing series of patients that he's stented across
you want a
the
stent boost?
left main, not
Go
kissed,
up.
and has OCT them 8 or 9 months later, and
No,
shows
14,
basically a
18,
film of
18, 20,
the
down.
constructs. So it's really, Ronnie, can you hear us?
I can hear you very well now. Are we?
Oh, great. So Ronnie, while you were working, we were talking about your excellent work on the left main OCT and seeing what happens to the side branch without a kiss. So can you highlight some of the features of that work for us? Because it's very interesting. Dr. Latif just asked whether or not we should mandatory kiss.
Yes, and that's a very important point, and that's what I wanted to show you here today also. See, right now I've done a pot. The issue is the circumflex ostium looks very good in this view. However,
OCT theta.
no, I want to have another wire to cross into the L-cirx ostium distally. So what happens is, depending on the lie of the strut across the circumflex ostium, if you're unlucky, you will have a connector or crown of the stent across the L-cirx ostium. And angiographically, you cannot see this. So you think it's a good angiographic result and you will decide that you're not going to kiss it. But if you do not kiss this, over a period of time, you have neointimal growth that takes place into this and leading to restenosis. And Ziad and me have been working on this, and we have got some 8 or 9 patients that show this. And I think we're still doing a follow-up on some of our patients to decide how it looks. So what I'm going to do right now is do the same thing. Come to the heliocaudal view.
LED wire.
Yeah.
So you have an IFR wire, Ronnie. What about stenting across, doing an IFR, and if it's completely normal, does that help guide you or not based on this?
No, it's going to be normal, but then I would go only by OCT in this situation because the IFR is going to be normal. There is no pinch. The issue is not whether there's a flow disturbance or whether there is the question is there a strut across the L-cirx ostium? And if I can just cross this and then show you an OCT, I could decide on that. Give me a small puff. So I'm going to try.
It's the next
to-
and Carina alignment.
Yeah.
No cusp alignment.
Can you puff? Right. So I think I've crossed distally. So now if you look at the two wires, the jailed wire and the wire across the circumflex, you see there's a gap between the two. So that's a very crude way to know that you have done a distal cross. But then of course we got to confirm with an OCT. So what I've done right now is I've got the LAD wire, I've got the circumflex wire, and now I'm going to have jailed wire, and now I'll pull the jailed wire out very carefully without the guide hitting the left main. So I pull the jailed wire out, and now I'm going to use the OCT catheter and show you an OCT to decide whether we have actually gone through the distal strut. Give me the OCT catheter.
Which catheter do you have available to you? Do you have OpStar now, Ronnie?
No, we got the Optis with us.
So, in the past, one of the problems with the Optis was it was a little bit floppy and had difficulty as a rapid exchange getting to the circumflex. The OpStar is really a major advancement. It's a lot more sturdy,
Yeah.
shorter rapid exchange and easier to track into the circumflex. So hats off to the engineers who made a significant leap by helping us with the catheter.
Entirely agree with you on that. The catheter which we have right now is a catheter that the monorail part is a little flimsy, and you really find it difficult sending it into the circumflex. Sometimes you do find it difficult sending it the third or fourth time in the same case too. So right now what I'm doing is I'm just trying to send the OCT catheter into the LAD, and we'll do a shoot there.
Okay.
Good. So are we ready for the shoot?
The port.
Okay.
Right.
Good. So can you go live on the OCT?
So Ronnie, let me ask you one key question here. Is this high resolution on purpose in the left main for this specific purpose, or are you a high res guy? Although I'm sure you are.
Yeah, but see, it's a very good question. It's very important that you do a high-res shoot on this, because now we're not looking at the MLD max, we are looking at the strut. And if you want to see the strut, you need a high-resolution picture. And that's why I'm going with a high resolution at this point, because without a high resolution, we will not be able to see the strut across the circumflex. So now, let me try and show you. No, I think there has been some blood that have gone across. Come, let's go for a reshoot, because I think the shoot has not been good.
When do you use high res?
Yeah, let's go for a new run, please. Quickly go for a new run.
But I think Ronnie's point is well taken. It's a very specific question on the crossing of the strut, so you want less spacing. But other than this, I don't
Injecting?
see no application.
I think strut crossing and stent fracture would be the two places that I could think that you'd really want to do this.
And even fracture is difficult sometimes, right?
So when I show this, you got to go to the LAD and dilate the LAD.
Okay. I'll take the 3.5.
I would also say
3.5.
BMS, but we'll have to ask Chuck when it's coming back.
Great. So
3.5.
now we have done the OCT. I hope you're able to see the OCT
3.5.
pictures there. Let's go to the LM bifurcation, get the rendered stent in, and run this first. Let us see how our stent looks. Good. So now please show the OCT on the main screen.
So you have an 8-minute warning.
But
But you're working beautifully well. We have about 8 minutes left. So
right. So if you look at the stent in the LAD, it's definitely under expanded. So we're going to go, Jabir is going to go up and he's going to use a 3.5 balloon and expand this in the LAD, because we have not done, we didn't expand the LAD, we just did a port. Because I wanted to show you about the circumflex ostium. So right now, this is the circumflex ostium that we see there. And we are going into the LM, the wire that's coming there. Good. So now let us have a look at the 3D bifurcation view at the L-circ ostium, right?
So Ronnie, tell us what's the MLA at the ostium?
Okay, go.
Is it pinched?
No, on angiographically it's not pinched. While I'm going to show you a 3D bifurcation view right now, and I'll show you the the LM bifurcation.
But on your longitudinal profile here, there does seem to be
Can you rotate it to the?
some area of pinching. Is that
No,
Okay.
we'll have a look at it.
okay?
18, 20. 18, 20.
So walk us through what. So right now you're in the left main proper,
Yeah.
right? You're not next to the
Okay.
bench.
No, I mean the left main, and I'm slowly moving to the circumflex. So I'm just trying to see over here. So now you look at the circumflex ostium that's just coming over here. Now, can you do
beautiful.
look at that? Now, if you look at this, can you rotate this? I'll rotate it a little bit. You see, there is the lower part, there is a little bit struts there, but if you look at this wire, the wire has gone distal to that crown there. I hope you can make that out. The wire
We
is
certainly can.
in between the crown and the valley, but there is a strut that is a connector across. And this connector across is after some years, there will be neointimal growth at this particular point, and what we normally will find is that this divides the L-sus ostium into two. Can we do a lateral rotation also there, and you'll be able to see this out much better. So what I normally do is, even though the ostium looks good, since you've got a connector there, I believe we should go and do a soft kiss and remove that connector out of that L-sus ostium. And that's one of the most important points that I wanted to show you. And we just had a situation where we have a connector right across the L-sus ostium. Though angiographically, if you look, the L-sus ostium looks brilliant.
So, Ronnie, there, it looks like there's a cell distal to it. Would you try to rewire into that more distal cell, or would you dilate here and expect the connector to move out of the way because it's only a single connector?
Yes. Now, let's go back to that. Have a look at it. So what I normally do is, see, if we do cross through the distal, the strut there that you see, that's a valley there, distally.
2.5.
So you would find it difficult to cross with the balloon, and you will really distort the stent at that point. So here what we just need to do is just get that connector to move out of the ostium. It doesn't need to be a high pressure. Just a low pressure balloon would do well enough. So, but you need to kiss it. So you would probably take a 3.512 into the LAD, and I would take maybe a 2.75 into the circumflex ostium and just move that strut across. So I think if you have time.
Do you use your OCT? Do you use the OCT to size that balloon?
Yes,
Like, is it an undersized balloon?
no, into the circumflex is an undersized balloon.
2.5, you want to change
No,
to 2.7.
first 3.5 in the LED.
Lady. 3.5.
So a couple comments about the data regarding this. So the OCT 3D study from
3.5.
Japan tested this in about 300 patients. The clinical outcomes at 1 year were not different, but there was a significant improvement in the total uncovered area, if that's the right way to describe it, of the ostium if you were going through the distal cell. And this is also being tested prospectively in the October study by Niels Holm and Evald Christensen, which is currently randomizing.
So let's go to the eleocaudal view. So what we're going to do is we're going to do a quick kiss so that we would be, if time permits us, we will. This is 3.5.
This is 3.5.
Right.
It'll have to be a peck because we have 3 minutes left.
Oh, so in that case, I will probably hold the wire. So I'll probably be able to show you this results of this kiss only a little later. But the plan is that. So what you're going to do is put a 3.5 balloon into the LAD and take a 2.75 into the circumflex and do what we call as a soft kiss.
So the good news is, Ronnie, Balbir is going to talk to us in a short lecture a little bit later on about to kiss or not to kiss. So we'll have more on this if we
good.
end
So
up running out of time.
So in case you're running out of time, before I end, and let me thank you on behalf of all my colleagues out here for giving us this opportunity. It was a nice time I had, and we should meet again in future.
Well, I mean, certainly you did a masterful job in an extremely short period of time. Next time I'll give you 15 minutes, and then maybe you can do a CTO. So, and no, we're delighted to have this. We're interested in your strategy. It made for good discussion. We're delighted to see MLD Max and the impact of both eye optical and light lab all across the globe. And it's going to show that, in fact, intravascular imaging is indeed going global. So thank you for joining us. So, Haram, while we've got 2 minutes, the ACS imaging?
True images,
Yeah,
yes.
that first case, you know, like, you've purchased the OCT catheter.
Can you
you
dilate
know,
the LED?
It's an ACS.
Can you
so
dilate the LED?
So it's interesting that if you, I don't know why not to embrace imaging.
I'm at 10.
I
10.
I'm on the camp of image everybody, and the patients that I
Right,
don't
now.
image, when there is a mechanical.
Can we have the fluoro please on the main thing, right?
of
So
getting free.
dilate that,
imaging.
dilate the
Right,
circumflex. Don't
but
confuse,
ACS,
dilate
I
the
think we
circumflex.
benefit tremendously because it's a lot about
I'm at 8.
length
That's
of
it.
time. Like even the
Down.
RCA, I was surprised with the length of the stent. I think was angio driven only.
Yeah.
So-
I wanted
Shall we
to
please?
change your
LED
perception
12.
because there is so
Go,
much
LED
time
12.
going on and
LED 12.
the normal vessel there, you change a 38 by a 15.
I think the contribution of spasm and
Down.
sympathetic drive for a patient.
Now
with ACS
together
is-
4.
Go,
1 second. Go to 4.
Go sister to 4.
And needs to be
4.
accounted for in your side.
We are at 4.
This is
6,
a little
8,
bit,
6,
8,
what we see
8,
on CTO.
down.
Right, yeah,
That's
like
the
that,
under-
Which is the LED?
Underperfused
Which
is the
vessel,
LED?
normal
Sister.
vessel.
So we are gonna move on to
So
Ajit Mosari.
I finished
This
the
is honestly one of the most exciting areas of imaging guided PCI that I've seen. I'm delighted that you guys are going to be able to see it. It's OCT guided deferral of stent
and they are wired
in
as
STEMI patient calcified
well.
nodule.
They are also moving
Is
out.
at
So
core lab, he does some amazing work. I had the chance to visit him. Ajit,
Thank
thank you so much for joining us.
No,
Talk
no,
to us
yeah,
about
yeah.
your deferral program and how you're changing the game.
Thanks, Sid, for this opportunity. Can you hear me, please, and see my slides?
Yes.
Can you give me
We
another
can.
wire, please?
So, I'm just going to show you a couple of cases on.
Can you give me another wire?
Calcified
Yeah.
nodule, which I ended up stenting with blue
Are we
units.
still on
But I
wire?
show you some of very
Give me the LED wire.
interesting cases that we deferred stent implantation in stent.
The wire wrap
So
on
this is a
there.
patient who's typically 24
That is why I inflated that to send the
Yeah.
circumflex inside.
Years, smokers, just discomfort for an hour, EKG anterior wall.
Have a fluoro?
Yeah, no, not a fluoro.
In the ER showing anterior wall motion abdominal.
Right, now
Load it up.
after this we'll just do an OCD run.
OCT.
That's
Because
it.
in case we can show them that we can show them the OCD run if they are permitting
And
us.
that's what the angiogram shows, a clear cut lesion in
Yeah.
the LAD, full of thrombus,
Yeah,
and just
yeah.
a single vessel lesion. So
Good.
what do you
Give me
do
the
with
OCT.
these patients? And we've used many techniques. One thing is clear, we don't go in
30 minutes is too less, no?
Too less.
Physiology, imaging, everything.
Yeah.
So we've used suction catheters, we've used sections, everything, but we changed our strategies of late. And here we use
Case
thrombolysis, and this is a standard procedure for large thrombosis that we use.
Yeah, this, if we got another 10 minutes, if we could have shown this, that would have been beautiful.
2.53 boluses, and you can see what happens immediately. In about 10 minutes, the coronaries start looking much better. The
But they
flows
know
are
about the
better,
work we are
there's
doing
no
on
slur
circumflex
flow.
osteo.
The coronaries are having free flow, the patient is paying.
Sister wire എല്ലാം അഡ്ജസ്റ്റ് ചെയ്ത് ഇനിയിപ്പോൾ നമുക്ക് സമാധാനം ഉണ്ടല്ലോ അല്ലേ കാണിച്ചു തന്നെ
You would not touch this vessel anymore because there's still thrombus there, there's sort of lice in the vessel. We could
Right.
show you on an X
Okay.
which we used to use to be
Okay, fine.
Now, with better antiplatelets like ticagrelor, we don't do literally.
Are we injecting 5? Because it seems we're not injecting 5.
We are at 520.
520. Eh?
620.
6 Aki. Yeah, okay.
The coronaries looking much cleaner.
Right.
You look at the OCT imaging, and you can see very, very clearly that there is just some thrombus there. Very clearly, there's a plaque erosion with the thrombus. The lumens are very big, and it's more than 2 millimeters. And then in this sort of
Fantastic.
scenario, we don't
Good.
stent these patients.
So now
Discontinue.
let us have a look at that.
Actually, no stents in this.
Show me the 3D bifurcation view.
Patient, 33 years old.
Santosh and then last time confusion left main bifurcation കാണിക്കാൻ സന്തോഷിന് അധികം നേരം വർക്ക് ചെയ്യുന്നില്ലെന്ന് തോന്നുന്നു ഇപ്പം ഈ ഒ സി ടിയിൽ
Next morning, the cath lab
Right.
is much better here. And again, you can see the stuff in the coronaries, very ugly looking, thrombus containing region in the left ventricle descending. So here's a patient who we treated medically, is stable now, the flows are good.
Oh,
but we
See,
moved
look
away.
at that.
It's moved away.
Look through the.
Just give
It's
them,
beautiful.
With a 8
Give-
millimeter.
Give me 4.5 4.8 ആണ് പോട്ട് ചെയ്യാൻ വേണ്ടി ആ പോട്ട് ശരിയല്ല. ഷോ മീ ദ ഓസ്റ്റിയം ഓർ ദ സ്ട്രട്ട് LM ഓസ്റ്റിയം. ഇങ്ങനെ സന്തോഷം കാണിക്കണ്ടേ ചോദിക്കുമ്പോ കേട്ടോ, ഇത് എന്ത് വേഗം വന്ന് കാണിച്ചു, ലാസ്റ്റ് ടൈം അത് ഇത്രയും വേഗം കാണിച്ചില്ലല്ലോ. Right, it's not proximal. There's a malposition there.
There is an
അത് എത്ര 4.5 എടുക്കാം.
അടുത്തത് നമ്മൾ കാണിക്കുമ്പോൾ നമ്മൾ 4 പേരുടെ പേര് എവിടെയെങ്കിലും എഴുതണം.
ഇല്ലില്ല, ഇറ്റ്സ് വെരി ഗുഡ്.
ഇതിനല്ല നമ്മുടെ അടുത്ത ലൈവിംഗ് ബോക്സ് കേസ് ബോക്സിന് പേര് എവിടെയെങ്കിലും എഴുതി കാണിക്കണം ഓപ്പറേറ്റേഴ്സ്.
Even though, you know, it's a large thrombus, the areas are good. We would just wait on these patients, given the non-invasive nature of the thrombus, the lack of vector ischemia.
Eleo caudal view, please.
These large thrombuses, we have now shifted to more aggressive strategy of using warfarin, and recently in the affordable patients, Novax, along with the next.
Go sister.
We were discharged the
3,
patient
4,
with narcotic
6, 8.
Returned for an angioplasty with an OCP at 6 week wait, and you can see that it almost looks absolutely normal in the coronaries, and it would have been the OCP at this point of time in 6 weeks clearly shows the vessel is absolutely cleaned up. There is just a
more out.
thrombus sitting there.
Sister, you must go up immediately.
And, you know, we've now got 6 months OCPs
Go
on
up.
many of these patients, especially these are red thrombi.
10,
Really see cleaning up
12.
the vessels with warfarin and a single antiplatelet after
See, we have got the osteum. That's
Yeah.
very good. Down.
Follow these patients up.
That shows a crude method of no malposition.
No malposition.
Before and how the arteries now.
So now
Very, very clear.
I push the guide
I
inside.
think the conclusion is that large thrombus burden, which is a
Now we'll do 2 shoots here, 1 shoot here, 1 in the PA caudal view.
We just published heart lung circulation data of 2,400 STEMItes, of which 24% of them were young myocardial infarction, 33% are smokers. A lot of them had large.
That's very good, alle.
Excellent.
Nightmare to the interventionalists.
Let's get a PA caudal view.
We took a 4.5 last one.
Suggested.
We did the initial port with 4, then the final with 4.5, and the LED post dilated with 3.5.
I would consider this result to be good. You have done a 3.5 there. and I-
3.5, 4, 4.5.
That's
These patients
Shall
So-
we take out the wires and do a final shot?
Yeah, so that I do send that.
Take an LA caudal so that we can have the carina profile.
I think OCP helps in selecting the type of treatment based on residual lumen area.
Yeah, carina is profiled, so we'll take.
So this is my conclusion of my talk. and
Beautiful
I'm
carina.
happy to take questions on this area.
Thank you.
Thank you so much. I mean, wow. Andy, how about?
I thought he's telling us that he's not seeing that.
Well, is this the?
But I think we should show this if possible.
Yeah.
Okay.
You know, I don't know.
Yeah. Do we need to do a distal shoot PA cranial? If you can connect back and let them show us the final result, it would be great. If there is somebody in the US listening to us.
Fine. This one is fine. Shall we remove everything?
No, I think they are not listening to us. They are frozen with Dr. Ajit Mullashiri, right? Yeah, right. Okay.
നമ്മുടെ യൂഷ്വൽ സ്റ്റൈലിൽ ഞാൻ പറഞ്ഞു നമുക്ക് നേരത്തെ പകുതി ചെയ്ത് വെച്ചാൽ
അല്ല ഇതിങ്ങനെ ചെയ്യണം നമ്മൾ ലെഫ്റ്റ് മെയിൻ ഡയലേറ്റേഷനോ ഡിസ്റ്റൽ ക്രോസിങ്ങോ കാണിക്കണം വെരി